everyone's permission, I'm starting with today's live now. Greetings and a warm welcome to all the dignitaries present here. I am Shwastika from Team Clearnet, serving as the allocated session assistant to ensure a seamless experience. Clearnet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. Clearnet is elated to be chosen, and it is a great pride Clearnet serves as a digital partner for this event. And the focus of today's session is traumatic brain injury. And now I would like to invite Dr. Meenakshi Sundaram, sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former national vice president of the Indian Society of Anesthesiologists and has held key positions including governing council member, president, and state secretary of the ISA Tamil Nadu state branch. Now, sir, we can proceed the session, sir. Over to you, sir.
Thank you very much. At the outset, I request our city branch president, Dr. Munian, to offer his presidential address.
Good evening, all. On behalf of ISA Puthukkottai City Branch, I welcome the moderator, faculties, and the delegates for the eminent online program conducting in the name of Puthukkottai Bhudhan by Puthukkottai City Branch. Today, we are conducting 29th episode of second edition of Puthukkottai Bhudhan. Today, we are going to talk about the traumatic brain injuries. There are eminent speakers in our session. We are going to listen. Traumatic brain injury are a significant public health problems globally, which will affect the millions of people every year. As a result, the individual will develop morbidity, mortality, and disability. So, traumatic brain injuries require immediate attentions and proper managements. Understanding the traumatic brain injuries, by definitions, traumatic brain injury occurs when sudden impact or force causes damage to the brain and resulting from falls from height and RTA, road traffic accidents and violence and sports injuries and all. Based on the extent of injuries, the injuries can be classified into mild, moderate, and severe. What are the symptoms of traumatic brain injuries? Which will include a headache, vomiting, dizziness, loss of consciousness, and mood changes. Based on the severity, we got to assess the patient perioperatively by what are the key components of the perioperative assessments. Is a Glasgow Coma Scale, which is used to assess the level of consciousness and the neurological functions. Under neurological examinations, we got to assess the pupillary response, motor functions, and sensory functions. Imaging studies like CT scan and MRI used to assess the level of injury and the extent of injuries. Vital signs, we have to record the proper heart rate and blood pressures and respiratory rate to assess the cerebral perfusions and the intracranial pressures. Anesthetic considerations, airway management, we have to secure the airway, but keeping in mind not to increase the intracranial pressures. Hemodynamic stability, we have to maintain the stable heart rate and blood pressures to facilitate the cerebral perfusion pressures. Cerebral protections, we have to use the anesthetic technique and agents, but keeping in mind to facilitate the intracerebral oxygenations. And intraoperative management, we have to use the induction agents, propofol and etomidate, which will maintain the normal intracranial pressures. And the ventilation strategies, we have to maintain the hypercapnia, normocapnia and hypercapnia, not to stimulate the hypercapnia. And also fluid management, we have to use isotonic fluids to avoid intracerebral edema. And based on monitoring, intracerebral monitoring, continuous intracerebral monitoring, which will aid the therapeutic interventions. Cerebral oxygenations, which can be assessed by jugular venous oximetry and near infrared oximetry. And post-operative care, neurocritical care, such patients are shifted from the theater to neurocritical patients. Pain and sedations, we have to minimize the sedative agents to assess the level of consciousness, and we have to use adequate pain control. And we also need a multidisciplinary approach like anesthetist, and neurosurgeon, and intensivist. Based on we got to monitor the neurological patients. Our speakers are interested to share their experience with all of us. Let's listen the online webinar. Before concluding, I want, based on behalf of ISA Puthukkottai City Branch, we thank all the ISA members who have voted for their academic chairman, Dr. Meenakshi Sundaram, and elected as a national president. Once again, thank you all the ISANs. Great thanks to all the ISANs. Thank you, sir.
Thank you, Mr. President. Now I request our Secretary, Dr. Kannan, to offer his secretary report.
Good evening all. I am Dr. Kannan, Secretary, ISA Puthukkottai City Branch. Successfully, we are conducting 29th webinar of second edition of Puthukkottai Bhudhan today. Today, our topic is traumatic brain injury. Last week, 13th July, we have conducted 28th webinar of second edition of Puthukkottai Bhudhan. The topic was cardiac patient for non-cardiac surgeries. We have divided the topic into 3 subtopics. First one is regional anesthesia for thoracic surgery. Second one is management of valvular heart disease patients coming for non-cardiac surgery. Third subtopic, management of congenital heart diseases patients coming for non-cardiac surgery. Our moderator was Dr. S. Kumar, Senior Consultant and Head of Cardiac Anesthesia, Meenakshi Mission Hospital, Tamil Nadu. First, Resident Cardiothoracic Anesthesia, valvular heart disease patients coming on the end.
I think his internet is unstable, but last week webinar was on non-cardiac surgery, patients with cardiac disease.
Sir, I am here, sir. Sir, I am here.
Continue.
There is a history, a great history made by our ISA Puthukkottai City Branch. Our senior member, Dr. Meenakshi Sundaram sir, and our academic chairman, Dr. Meenakshi Sundaram has selected us elect national president 2025. Our city branch, thank you all members who have voted for our academic chairman. We are very happy to share this news. Thank you all. Thank you all members. Thank you, sir.
Thank you, Mr. Secretary. Now it is my duty to introduce the speakers to the delegates. But at the outset, I thank, this is the first time I'm talking about the election in Puthukkottai Bhudhan, because usually I will not mix up academic and election scenarios. But I profusely thank for the simple reason, Puthukkottai branch is only 4 years old. Even before entering LKG, it has come out with a master's degree. That is achievement for Puthukkottai, because I think even in future, it would be very difficult for a branch established just 5 years ago, having a member as president-elect. That can never happen. But Puthukkottai already, it has arranged ISA-sponsored CME, on his own CME, and 2 ultrasound-guided nerve block workshops, and even a CME inaugurated by 2 state ministers and 1 MLA. So it has so many credits, and I think Puthukkottai succeeded in having a president because of the solid effort of pan-India actually. All the members and even congratulatory messages were plenty. More than 3 hours yesterday, I attended the congratulatory calls. That means Puthukkottai has reached on top. As they have made me as president-elect, I thank you, all the members of ISA National, because it is a pan-India voting, and they made it possible. So from the bottom of my heart, I thank. And see, on 30th, before pre-election, actually 1 day is a holiday election campaign. 31st you cannot campaign. So 30th we had the session, and luckily this webinar comes after election. So it is pre-election and this is post-election. So I was a little bit comfortable today, and we have to go with another 23 webinars in the days to come. And today, usually the youngster will be a postgraduate. Here, the youngster is a postgraduate, but he is a DM postgraduate. That is the problem. So he is also a senior person, and he is Dr. Rajasekar, and he graduated from Manakula Vinayagar Medical College, MBBS, and he has done MD anesthesia in JIPMER. Now see, he is in Puducherry only in JIPMER, and he is doing DM neuro anesthesia in JIPMER. So JIPMER is one of the reputed institutions across the country. So he is doing his post-graduation there. So we welcome him. And see, he is already a DM neuro anesthesia. So he will be followed by Dr. RakulPrasath. RakulPrasath is an anesthesiologist from Trichy. So to be precise, he is also a neuroanesthesiologist. And he has done his MBBS from Puducherry Medical College. And as he has done his MD in JIPMER, he has done his MD in PGH Chandigarh. So usually 3 institutes are popular across the country: JIPMER, PGA, and All India Institute. And these people are doing this. And another prestigious institute is NIMHANS. So Dr. RakulPrasath has done his DM neuroanesthesia from JIPMER. So with all these qualifications, he has come to Trichy, and he is working as a consultant in Neuro 1 hospital, which is a premier neurosurgical center. So these 2 neuroanesthetists will be followed by a professor in neuroanesthesia. He is Dr.SriGanesh, a high-end academician from Bangalore, because he has graduated, RakulPrasath is graduated from NIMHANS Bangalore, and he is a professor in NIMHANS Bangalore, training so many RakulPrasaths there. And he is a former Bangalore ISA secretary. He is a former Karnataka secretary. He has not mentioned it, but I know he is a Karnataka secretary for a simple reason. I used to post thrice this Puthukkottai Bhudhan in my previous edition to make it popular. At that time, the first reply from this man came: "Sir, how many times you will post the same message?" So that much his brain was traumatized by the third message. So now I am stopping with the 2 messages in the second edition. So probably in the third edition, I may stop with 1 message. So because of that trauma SriGanesh acquired during my first postings of Puthukkottai Bhudhan, now he is going to talk about traumatic brain injury. And we welcome SriGanesh, and he is interested in traveling. As he is working in NIMHANS, he will travel majority of the times inside NIMHANS only. He is a workaholic, but he is saying traveling, I don't know where he travels. It is very difficult to see him outside Karnataka. And such a big people, top people, they will be moderated by Dr. Prasanna Bidkar. He is a JIPMER professor. See, 2 postgraduates. One did his MD in JIPMER. His professor is there. Another one did his DM. His professor is also here. So it is a nice conglomeration of anesthesiologists. And Dr. Prasanna Bidkar is a professor of neuroanesthesiology and neurocritical care. At the same time, he is interested in playing badminton and cricket. Then I was wondering how he maintains his shape again, in spite of playing badminton and cricket. In addition, he is going for a morning walk alongside the beach as he is in Pondicherry. Then he should be a lean man, but he is not like that. Then only I realized he is a foodie. He is interested in taking a lot of food. So he will go for a morning walk along the beach side, and he will take 2 vada and 1 dosa and a coffee. So I think that may be his routine, because his stature speaks about that. Now these 4 neuroanesthesiologists are going to ventilate our brain. Your brain will not be traumatized. They will be ventilating your brain gently as a breeze by their knowledge, but they can only ventilate. It is our duty to keep our brain perfused. They cannot do that. They can ventilate. So you keep your brain perfused to avoid ventilation perfusion mismatch. Now, Dr. Prasanna Bidkar, sir, over to you.
Thank you, sir. Thank you for the introduction. So without wasting much time, that we have three important topics today. One is on physiology, and then the anesthesia management of traumatic brain injury, followed by subarachnoid hemorrhage management. So may I request Dr. Rajasekar to move on to his topic, share the screen and deliver his lecture.
Sir. So good evening, everyone. Myself, Dr. Rajasekar from JIPMER. I'll be talking about a pre-anesthetic assessment in traumatic brain injury. So I would like to thank the organizers for giving me this opportunity, and I will also want to convey my wishes to Meenakshi Sundaram, sir, for being elected as the president of ISA. So before going to assess a patient with traumatic brain injury, we'll have to have a basic idea about the physiology. And one thing which is a must in knowing about cerebral physiology is the Monroe doctrine. So in a normal state, we know that the cranial vault is a closed vault, and it has mainly three components: a brain, the CSF, and the blood component. And these three coexist together, and any rise in one component the other two components would have to compensate for the increase in the primary component. So in case if there's an intracranial hematoma or there's a brain tumor just occupying the space along with the three components, the initial phase would be to compensate it. So the CSF would be let out to the spinal compartment, and there will be an increase in the venous outflow. This occurs in the earlier stages where there's this minimal compensation, but it cannot compensate for an excessive volumes. When there's an increase in the mass or the bleed, the compensation phase enters into something called as the decompensation phase, above which the brain cannot hold. So this can be simply explained by this pressure volume curve. So in a normal state, you can see that the brain is highly compliant and is containing the three components: the brain, the blood, and the CSF. So when you add an intracranial mass to it, initially there is a compensation phase. So any major increase in the volume is transcended by a minimal increase in pressure. But as the mass increases, the patient enters into the decompensation state, where even minimal changes in the volume can bring about drastic changes in the pressure, and ultimately patient can herniate, the brain can herniate. And these things are time dependent. So if a patient who is in compensated phase can rapidly go into decompensation and can herniate in a short time frame. So this is where the importance of traumatic brain injury comes. And I would like to start my presentation on TBI, the pre-anesthetic management of TBI, by saying that such patients who are presenting with TBI for emergency surgeries are considered as ASA category 5B. It means without the surgery, they might not survive. So there is no role for any preoperative optimization in these patients. There's going to be a quick phase of assessment, and simultaneous resuscitation, which is going to happen. The goals of preoperative evaluation will be to stabilize the general condition, to assess the neurological status, and to minimize the secondary brain injury as well. The primary injury, the trauma, has already happened. Our goal as anesthesiologists would be to manage or minimize the secondary brain injury, and to manage the airway, and to identify and treat the associated injuries. And this would happen simultaneously with the ATLS protocol as well. So we will see how our assessment and resuscitation happens along with ATLS. So the first one will be to airway management, to manage the airway and to stabilize the C-spine. So any patient with head injury, we consider him to have a cervical spine injury as well, unless it is ruled out. So the initial management will be to put him on a cervical collar and to prevent any further damage to the cervical spine. And in case if the patient needs to be intubated, say the patient is having a G less than 8, which he cannot protect his airway, the intubation has to be done with a manual inline stabilization in place, as shown in the image here, where the head is supported fixed across a board, either from behind or from the anterior. And during the intubation, the anterior part of the cervical collar can be removed to facilitate intubation. And any patient with trauma is considered full stomach, and hence RSI is indicated. So the question comes here whether to use choline or not. It's a very controversial thing, theoretically speaking. because of the theoretical risk of increased ICP with use of succinylcholine. But when you consider the patient who is not able to maintain his airway, is hypoxic, and is building up CO2, the rise of ICP due to that hypoxia and hypercarbia is going to be much more than the ICP that's going to rise with succinylcholine. So since the benefits outweigh the risks, you can very well use choline in case it's indicated. The other agent which is usually accused of raising the ICP is ketamine. But nowadays, it has also been used routinely to intubate patients with TBI. And obviously, patients whose hemodynamically unstable, ketamine is going to be the much better choice than propofol. And the use of video laryngoscope will come into picture in patients such as this on the image on the right, where the patients are coming with not just a head injury, but also with panfacial fractures, Lefort's fracture, where the patient will present obviously with an difficult airway. So in that situations, video laryngoscope is going to aid you to reduce the laryngoscopy response, laryngoscopic time, and thereby reducing the ICP surges. The second component would be to maintain the breathing and ventilation. So maintaining oxygenation is very important. So in case of severe TBI, when the GCS is going to be less than 8, obviously we are going to intubate. But even if the patient is score is above 8, continue oxygenation via the face masks to maintain a target of PO2 above 60, because PO2 less than 60 is going to drastically improve the cerebral blood flow, heighten the cerebral blood flow, which is indirectly going to increase the ICP. Also, maintain normocarbia, a peak PO2 range of 35 to 42. Avoid hyperventilation in the initial phases because it can drastically reduce the cerebral blood flow and can in turn cause secondary brain injury. Reserve hyperventilation strategies only to when the patient is having excessive ICP surges. So the third component would be to assess the vitals of the patient. So the target for us, as per the Brain Trauma Foundation guidelines, is to have a systolic blood pressure more than 100 in patients between age group of 50 and 70. And in the patients above and below that age group, the systolic blood pressure of 110 is recommended by the Brain Trauma Foundation. And to resuscitate them, isotonic crystalloids are recommended than colloids. The role of colloids is still controversial. And also do not over-treat them or over-sedate with them with blood products, because the target hemoglobin of 7 to 9 is proven to be sufficient, and any over-treatment is not proven to have better outcomes. And the choice of vasopressor is still controversial. It's like there's no single vasopressor of choice in the setting of traumatic brain injury to maintain a blood pressure. The fifth component would be, we'll come to the fourth component later because that is the most important component. The fifth component would be to have an exposure and the process for other injuries. So our patients, we might present with hemothorax, hemopneumothorax that might in turn affect your oxygenation as well as the vitals. So other injuries, long bone fractures, those things also have to be ruled out in this phase. And one more injury which can cause more bleeding is the scalp laceration due to its scalp's immense vascular blood supply. And key pictures like the findings like the battle sign, the raccoon sign can also point towards base of skull fractures. And in the term of exposure, do not put the patient into an hypothermic phase. That might also cause an secondary brain injury. So the most important part of your pre-anesthetic assessment in patients with traumatic brain injury will be to evaluate the neurological disabilities. The primary score, which will give you an it can be used as both as a prognosticating score as well as to evaluate them, will be the GCS. I'm not going into the depth of GCS, which will be assessed with using 3 components: the eye opening, the verbal response, and the motor response. And we know that the GCS less than 8 is called a severe traumatic brain injury. Those are the patients who frequently come to OT or get posted for an surgery. The second thing would be to assess for the pupils. So any signs of anisocoria would suggest that there's an increased ICP. And also in sensory neurological deficits can help you identify the lesions. And also posturing. So decorticating or decerebrate posturing will also help you prognosticate. And clinically, you'll have to look for signs of raised ICP, namely the Cushing's triad, which is hypertension, bradycardia, and irregular respirations. So you also have to watch for that and treat them accordingly. The one investigation that you would like in patients with traumatic brain injury would be NCCT brain or the neuroimaging. Do not usually wait for the lab values to take up the patient, or the surgeries are time sensitive. So the one imaging which will help is the NCCT brain, which is the first line imaging. It will help you identify the type of injury, whether it's an extraaxial injury or an parenchymal injury, whether it's an STH, EDH. And it can also help you locate the locate the hematoma, and you can find out the size of the hematoma or the volume of the hematoma. This and the midline shift as well. So this will help you know how the patient would respond intraoperatively. There can take a patient with acute brain bulge, or there could be excessive blood loss. So this you can plan based on the intraoperative plans based on your preoperative imaging as well. And also CT spine to rule out AV management is going to be important for us. So as a part of the trauma protocols, most of the hospitals include CT spine ruling as well. Otherwise, if CT spine imaging is indicated, follow based on the Nexus criteria or the Canadian C spine rule. MRI is usually reserved for patients to diagnose diffuse axonal injury and spinal cord injuries. So the first line of choice or the only investigation that you would require is an interCT brain. So here are three different images. The first one showing the lens-shaped hyperdense lesion in the frontal temporal region of the EDH. And you can see the second image showing the concave convex STH with a massive midline shift. And the third image where there is an parenchymal injury, the bifrontal contusions are seen this. So this would give you a clue about how the patients are going to behave intraoperatively as well. So the other key management steps are the things that you should, the medications which you'll have to look on your pre-anesthetic evaluation would be if the patient has received the seizure prophylaxis, the hyperosmolar agents which are going to be key, whether it is maybe mannitol or 3% NS, and other physiological things to reduce the ICP as well, like head and elevation, keeping the neck in neutral position to drain the jugulars, and also adequately sedate and analgesize, give adequate analgesia because we don't want the patient bucking or being too much anxious. So these are also going to increase your ICP. And extremes of sugars are also harmful to the brain. So target and blood sugars of between 80 to 180. Also rule out coagulation abnormalities, and Trenexa can be safely given in patients with mild to moderate TBI as per the crash trials. And in case if an EVD is placed or an ICP monitoring is placed, target the ICP below 22. That is the recent addition in the Brain Trauma Foundation guidelines. And you can surrogately target and cerebral perfusion around 60 to 70 based on that. So I would like to end my presentation with an case scenario. So we have a 25-year-old male who was in an RTA, who was brought with an unconscious state since the accident. And we don't have any other medical history. This is how usually a patient presents. We don't have their past history usually. So the on examination, his GCS was 7/15, and the pupils are anisocoric. His right is 5 mm non-reactive and left is reactive. And these vitals are somewhat okay with a saturation of 94. He has a C-spine collar in place, and he does not have any other injuries. The investigations show an STH with an 7 mm midline shift, and his labs are mostly normal. So the key preoperative assessment points are his GCS is less than 8. So he is in severe TBI. He might not be able to protect his airway. So you will have to intubate him with RSI, either or preferably in the ED itself to prevent secondary brain injuries. So breathing, he's a saturation of 94. He's in broadened hypoxia. So prepare early for intubation. Circulation is blood pressure is maintained above 110. He already has anisocoria, so there's a possible uncal herniation. So you'll have to act fast. And ICP control measures like osmotic therapy and positioning should be done. And you also have to rule out the associated injuries and treat them. So once these are all done, the patient is usually posted for an emergency craniotomy under GA with RSI, since it's a trauma patient. And your intraoperative goals will be to maintain the cerebral perfusion pressure and to avoid any ICP surges. Thank you.
Thank you, Dr. Raj, for explaining the assessment, preoperative assessment of these patients. We will take the questions in the end by the delegates, and discussion we'll have in the end. This is what you explained, that these patients come as an emergency and there is not much time available even to do the routine investigation, as these are all time sensitive management surgeries. So to explain more that how we are going to manage particularly in the intraoperative period as the anesthetic management, now I request Dr.SriGanesh, Professor in NIMHANS, to give his presentation on anesthetic management of traumatic brain injury.
Thank you, Prasanna. Dr. Rajasekar has taken you through the pre-anesthetic management and evaluation, and also touched upon what are essential components of care of acute traumatic brain injury. There might be some repetition here because of the overlap of the topic as such. So kindly bear with me and treat it as refreshing your learnings. So the learning objectives are very simple. Understand the pathophysiology,
the perioperative management, including anesthesia management, and guidelines that are currently available on acute care of a patient with severe traumatic brain injury. Dr. Rajasekar has again mentioned this primary and secondary injury. So primary injury is the one that is caused by the initial trauma. Most often it is not correctable. And the lesions that we had here shown were hematomas such as EDH, SDH, the subdural or epidural hematomas, and contusions. It also can include diffuse axonal injury. The severity of the primary injury is the one that determines the patient's outcome most often. But there are secondary injuries as well, which occur subsequent to the primary injury, and it can be both intracranial inserts and systemic complications. Remember that this is where our role comes in to minimize or prevent the occurrence of these complications and to restore systemic physiology as early as possible. So the first thing that can happen after a severe traumatic brain injury is increasing the ICP, which as a consequence can lead to increased cerebral blood volume and reduce the cerebral perfusion. There are several things happening at the molecular level, which includes neuroinflammation, oxidative stress, alteration in the metabolism, eventually leading to edema, ischemia, and cell death. In the secondary complications, intracranial complications include occurrence of seizure, cerebral infarction, and the systemic complications, it can affect all the systems. So traumatic brain injury, though it affects the brain, can also affect several other organs, which includes heart in the form of myocardial dysfunction, pulmonary edema, stress ulcers, DVT, and acute kidney injury. Now, there are certain indications for surgery based on the type of traumatic brain injury lesions. However, that is not important for us as anesthesiologists. For us, what is important to note is that the surgery is indicated for reduction in the intracranial pressure by removal of the lesions and also performing a decompressive craniotomy to reduce the ICP. Now, why is there so much focus on intracranial pressure? And that is because the odds of good recovery or a poor recovery in the forms of severe disability or vegetative state for poor outcome increases by 7 times if the ICP is refractory to interventions, and by 4 times if the ICP is raised but is reducible. And therefore, managing ICP which is raised is very important. And this is a simplistic representation of how to approach a patient with raised ICP after traumatic brain injury. And if you can see, for almost all the steps except 2, anesthesiologists form a major role, which includes the first step, that is general prophylactic measures like intubation, mechanical ventilation, maintenance of oxygenation and carbon dioxide levels, blood pressure management, head and elevations, control of fever and glucose levels, and seizure prophylaxis. But there are 2 important steps where surgeon's role comes in. One is resection of the mass lesion and drainage of the CSF where feasible, and second one is decompressive craniotomy. All other steps can be managed by anesthesiologist and intensivist as a part of TBI care. Now, it's also important that we just not focus only on ICP because that is a major determinant. Because if you look at this figure, you can see that it's a well-played shot. Probably the ball has crossed the boundary, or it could be a 6 or a 4. And it represents, if you look at only one picture, that is ICP, one value that is ICP. But in reality, it is not the case. Most often, patients can have a mean arterial pressure of just 40, which translates into a cerebral perfusion pressure of only 20, which can be catastrophic for this particular patient. And therefore, it is important to look at the whole picture, both systemic and intracranial parameters, when we manage a patient. Now, what are the systemic parameters that can get deranged after acute traumatic brain injury? These are some of the factors: blood pressure, oxygen level, carbon dioxide, glucose, temperature, electrolyte levels, volume status, hemoglobin levels, and coagulation parameters. All these derangements can occur, and it is our role as anesthesiologists and intensivists to minimize the severity or the occurrence itself of these secondary complications. Now, this is a patient who is in the operating room, and this is a common situation where we see in severe traumatic brain injury, most often not adequately resuscitated in the preoperative period after arrival to the hospital. And why these 2 parameters are important, oxygenation and blood pressure? Because anesthesiologists are the primary caregivers who are involved in managing these 2 parameters. Not only that, the occurrence of hypoxia and hypotension can significantly worsen the patient's outcome. From this table, you can see that if the patient does not have hypoxia and hypotension but has only severe traumatic brain injury, his mortality occurrence rate are about 30%, 22%. Whereas if both hypoxia and hypotension are present, it increases substantially to say about 55%. And therefore, we play a significant role in minimizing the occurrence of hypotension and hypoxia. Now, we should look at the common causes for hypoxia. This could be decreased respiratory drive because of the traumatic brain injury. Patient could have aspirated because of his reduced sensorium. There could be lung and chest injuries, pain and causing inadequate breathing, and neurogenic pulmonary. These are some of the things. There could be more causes as well. How do you approach a patient with hypoxia after traumatic brain injury? Identify and correct the cause. And also, as anesthesiologists, we are very familiar with oxygenation measures, intubation, and ventilation. Now, coming to the hypotension, what are the probable causes? Most often, it is inadequate resuscitation of the blood loss and volume that is lost. Sometimes it could be adrenal suppression because of the hypothalamic perfusion deficiency. Another important cause is extracranial injuries. There is a liver contusion, there is a splenic injury, there is a long bone fractures. All these can lead to concealed hematoma and hypotension. Cardiac causes, as I mentioned, TBI is a multi-system disease and heart is also affected. There could be cardiac arrhythmias and cardiovascular dysfunction which can contribute to hypotension, which I will discuss in the subsequent slide. So how do we manage hypotension after TBI? Identify and correct the cause, manage with fluids, blood products, and vasopressor or inotrope as appropriate. Now, this was one case where the patient came to the OT, we intubated the patient, and then we had this significant arrhythmias with hypotension requiring high vasopressor dose, multiple vasopressor administration, and amiodarone, despite which the blood pressure could be stabilized, but we were worrying whether we need to proceed with the surgery in a compromised state of poor cerebral perfusion versus immediately operate and reduce the ICP. We discussed with the family, we discussed with the surgeon, and then thought that it is best to medically manage the patient, correct systemic physiology, and then consider, if required, surgery later. But we are lucky that this patient had a hydrocephalus, and just a placement of an external ventricular drain to drain the CSF and monitor the ICP helped in avoiding a surgery and also correcting the cardiac changes that were manifested. Sometimes a severe traumatic brain injury can cause myocardial dysfunction, and the most often it is severe traumatic brain injury which have myocardial dysfunction. This can present with ECG changes and also contractility issues. And it is associated with poor outcomes as well. So the patients with left ventricular dysfunction are more likely to stay in the hospital for longer periods, have mortality and poor GCS at discharge. Coming to the fluid management, it is very important because these patients volume status changes rapidly. Plus, during the surgery, there is blood loss, and therefore we need to place multiple IV, large bore IV access, correct fluid deficits. Dr. Rajasekar already mentioned to avoid hypotonic glucose contained solution. He also discussed about crystalloids and colloids. Currently, the crystalloids form the mainstay of management of fluid in the perioperative period. Mannitol and hypotension, I'll discuss it a little later. But what is important is that nowadays we have monitors which can provide you dynamic volume indices. And guiding our fluids based on dynamic fluid indices can lead to appropriate volume resuscitation without causing any lung complications or cardiac complications. At the same time, not risking the patient to be hypovolemic. Now, the transfusion trigger, I saw Rajasekar mentioned 7 to 9, 8 to 10 is what I have put here. There is no consensus what is the threshold for transfusion. It depends on ongoing surgery, depends on patient's cardiovascular status, age, and the pathology itself. So minimum of 7 to 8 is desirable, and we generally don't transfuse if the hemoglobin is more than 10. Again, the advantage nowadays is that we have point of care devices which you can use to continuously monitor for the hemoglobin and transfuse accordingly as and when necessary. Coming to the anesthetic induction, we have multiple agents that are available. Most often what we use are thiopentone and propofol. because of the cardiovascular depression that these drugs cause, and also the traumatic brain injury associated myocardial dysfunction. A lower dose may be appear to be prudent. Etomidate is another alternative because it causes minimal change in blood pressure but can sometimes lead to adrenal insufficiency. Ketamine also he mentioned in hemodynamically unstable patients, but there were questions about whether it can be used in patients with raised intracranial pressure. Nowadays, all anesthesiologists are innovative in nature. They use a combination of ketamine and propofol to nullify the adverse effects of individual drugs and get maximum benefit in terms of hemodynamic stability and also cerebral protection effects. Opioids and lignocaine to ablate stress response are very important. They cause very minimal effect on the ICP, but substantially reduce the hemodynamic response, which can further worsen the ICP if allowed to continue. So, which drug to use amongst those that are available? This was one study that we did recently, where we compared etomidate, thiopentone, and propofol for its effects on blood pressure and cerebral oxygenation. Please note that cerebral oxygenation changes minimally with other drugs because of its effects on blood pressure, but etomidate, because it maintains hemodynamics, it causes the maximal increase in regional cerebral oxygen saturation. There is a fall in cortisol with etomidate. It can also happen with thiopentone, but it is insignificant to cause any major problems. However, note that whatever agent you use for induction has minimal impact on patient outcome at discharge. So what drug you use may not be so important. How you use becomes very important. Now, what dose? Now, this is another question that comes commonly to the postgraduate's mind. Should I use the same dose that I use in other patients who are conscious coming for other types of surgeries, or the dose needs to be modified? Now, this was a study that we did, and we looked at the BIS at baseline. This was done by my colleagues at NIMHANS. We found that the BIS value on the normal side, pathological side, and versus the pathological side is different. In the pathological side, the baseline BIS before induction of anesthesia itself is very less. And so also depending on the severity of traumatic brain injury, you find that the BIS values are lowest on the injured side in patients with severe traumatic brain injury. Now, does it translate into the differential requirement of anesthetic induction agent? Yes. So here you see that the total dose of propofol requirement substantially reduces with the severity of traumatic brain injury. The time required to anesthetize the patient with traumatic brain injury is also shorter in patients with severe traumatic brain injury. Now, these needs to be kept in mind when we provide anesthesia for these patients. Now, coming to the airway, we have several issues in managing the airway in patients with TBI. One is physiological difficult airway because of raised ICP, hypoxia, hypercarbia, hypotension, etc. Full stomach, which is already mentioned, uncertain cervical spine, and inability to assess the airway in patients with obtunded consciousness. And last one is these patients can be agitated because of hypoxia. The patients can have hypotension because of inadequate resuscitation, but providing anesthetic induction to facilitate airway can cause hypotension. But if you don't do it, it can worsen the ICP because of agitation. So I think we need to balance things, and anesthesiologists are good at balancing things in life. So this comes handy here as well. Coming to the airway management, there is no best or safe technique. It depends on the urgency of the situation, the expertise or the skill that you have, and the resources that are available at that point of time. General guidance is that you need to perform an oral tracheal tube because skull-base fractures can be present in these patients. Dr. Rajasekar already mentioned about MILS, manual inline stabilization, laryngoscopy, rapid sequential record pressures. I will discuss the disadvantages of this in subsequent slide as well. He also alluded to hexamethonium and rocuronium. Now, rocuronium is available, so it can be used and it can be reversed as well with Sugamadex. Sometimes the patients may be intubated outside in the emergency room and come to you for anesthesia. It is always a good practice to reconfirm the airway, check for ventilation oxygen before you hand over to the surgeon. Physiological difficult airway I already mentioned, so you need to minimize secondary inserts. And when newer gadgets are available, should you use that as a first choice, or it has to be a rescue management? This, I think, needs to be individualized, but more and more people are now using newer gadgets, which includes video laryngoscopy as the first choice. Now, this is how manual inline stabilization is done and intubation is performed. As you can see from the figure, it can be performed both from the patient end and also from the foot end, from the head end and the foot end. And if you look at the figure carefully, you can see that most of the time this comes during off working hours at midnight. and you will see that there are at least 3 people on the screen and 1 person is inducing anesthesia. So it may become little impractical to perform manual inline stabilization, give required pressure, perform the intubation, and administer anesthetic agent. So I think pragmatism rules here. You need to think what is most important, and most important is to quickly, safely secure the airway. There's another problem with manual inline stabilization. Remember that only about 10% of the patients with TBI have suspected cervical spine injury and require manual inline stabilization. So 90% may not require this at all. And performing manual inline stabilization can worsen the laryngoscopic view, increase the intubation time, reduce the successful first attempt intubation, and worsen the Kornacki-Hine grades. So again, a practical point is use video laryngoscope. Preferably use a gum elastic bougie when you are not certain about the cervical spine. That causes minimal cervical spine movement, quick intubation without any increase in hemodynamics or ICP. Now coming to monitoring, a standard ASA monitoring most often is sufficient. But invasive blood pressure monitoring is definitely a good choice. It can be placed quickly. Central venous catheter placement takes time, so it can be done at end of the procedure for post-operative management. But if you feel there is time is sufficient and you can quickly place with ultrasound guidance and it will help in managing the patient better, it can be considered before surgery as well. Now coming to the maintenance, both intravenous and volatile anesthetic management is practiced. I think cerebral physiology was discussed earlier, so I'm not going to repeat it. But remember that whichever technique you use, you need to use it judiciously and as per the patient's requirement. Nitrous oxide definitely is a no, and opioids should be liberally used. This is a paper from JIPMER, which Prasanna and his group authored. They compared intravenous with inhalation and found that intravenous group had better ICP and brain relaxation scores as compared to inhalation agent group. So coming to the end of the post-operative recovery, ensure smooth recovery, that is the most important. But whether to extubate the patient on table or shift the patient to ICU is determined by several factors: patient preoperative status, cardiovascular stability, intraoperative brain status, in certain situations, availability of the ICU and monitoring facilities, and of course, your own judgment regarding how the patient is likely to behave in the post-operative period. Don't forget to give analgesia just because these patients are not fully conscious, and don't forget to be vigilant in both neurological and systemic monitoring in the post-operative period. Certain factors which we discussed earlier, secondary insults, can significantly result in favorable or unfavorable outcome depending on how you manage them. So this was just to highlight that aspect. Now I quickly move on to the guidelines that are currently available, which all of us can implement in our clinical practice. These are based on the quality of evidence. The recommendations are given. Please note that for most of the recommendation, there is no level 1 recommendation. And so based on the quality of evidences, these are graded. So ICP monitoring, it is recommended to reduce in-hospital and 2-week mortality. CPP monitoring, again, for same 2-week mortality reduction. Jugular venous oxygen saturation may be considered as to titrate your ventilation. I want to just highlight on this particular trial because most of us in most centers in India follow this imaging and clinical examination based management to manage ICP and manage a patient with TBI. Not all of us can have the luxury of measuring the ICP in all patients and managing this patient based on ICP. So this particular study showed no difference between ICP managed and imaging and clinical guided management in patients with TBI, and therefore we need not feel bad that we don't have an option to monitor the ICP. Our quality of care can be equivalent and the results similar with good quality care based on imaging and clinical examination. Now coming to the thresholds, blood pressure of more than 100 mm mercury for age between 50 to 69 and more than 110 between for other age groups. ICP threshold to treat should be 22. CPP should be managed between 60 and 70 mm mercury. SGVO2 values below 50 should be avoided. I'm just throwing some numbers for you to remember. But if you have facility and option to have multimodal monitoring, please use it because you can titrate the individual parameters to optimize the outcome. Coming to the treatment, decompressive craniotomy is not recommended to improve outcomes, but it definitely reduces the ICP and minimizes ICU days. So if it is performed, a large craniotomy should be performed. Prophylactic hypothermia, no role. CSF drainage to be considered where it is feasible. Remember that most of the time ventricles are collapsed. ICP placement of the ventricular drain may not be possible. So, but where feasible, it can be considered to quickly reduce the ICP. I'll come to this in the next slide. This guidelines only mention about mannitol dose and when to avoid and when to use. There are several papers, including ours, where we compared mannitol and hypertension and found no difference between the two. So you can use either. It is depending on how you play it, whether a grass court or a clay court. Some may be good in clay court, some may be good in grass court, but both are equivalent in their effect. So I would avoid mannitol if the patient is hypotensive. I would avoid hypertonic saline if the patient is in the hypernatremic side. Coming to the treatment, hyperventilation to a PaCO2 value below 25 mmHg is not recommended, definitely not in the first 24 hours, and definitely not without some form of monitoring for oxygenation. Barbiturate coma is not recommended. It can be only be used as a last resort to control refractory ICP, provided patient is hemodynamically stable. Again, as anesthesiology intensivist, we frequently manipulate the carbon dioxide level and PEEP to optimize ICP and also CO2 and oxygenation. So you can use simple techniques such as bedside ultrasound to guide your ICP based on optic nerve sheath diameter. And if you have a regional cerebral oxygen saturation monitor, both of them can non-invasively help you to identify optimal EtCO2 or PaCO2 and optimal PEEP to give the oxygenation. Coming to steroids, this is the only treatment recommendation which has a level 1 evidence, and it is not recommended. Nutrition should be initiated as early as possible. We generally do it on the 2nd day and full replacement by 5th day. Tracheostomy, early tracheostomy is recommended, and povidone care is not recommended. Coming to DVT prophylaxis, definitely recommended. Most of the centers do use mechanical prophylaxis, but chemical prophylaxis with low molecular heparin or unfractionated heparin is to be used if needed, but we need to consider the risk-benefit ratio before we do it. Currently, we do not have sufficient evidence to identify which agent to use, what dose to use, and when to start using it in patients with traumatic brain injury. Now, coming to seizure prophylaxis, phenytoin and levetiracetam both are currently used. Phenytoin is in the recommendation which was published in 2017, but both agents to be used only to decrease early post-traumatic seizure, not a long-term or a late post-traumatic seizure. So, we must remember that the quality of evidence is variable for different interventions that we do for patients with traumatic brain injury. For certain, the evidence is crystal clear, like steroids should not be used. But for many others, the quality of evidence is low, and therefore the level of recommendation is also poor. But when available, the resources are available, you should not make poor decisions. So when there is guideline available, please follow it, implement it. And several studies have shown that following the Brain Trauma Foundation guidelines results in better outcome for our patients. Follow protocols, but also use common sense. Just because the guideline says maintain BP of at least 100 does not mean 101 systolic blood pressure is good enough for your particular patient. You need to use common sense based on the scenario that is in front of you. To summarize, traumatic brain injury is the leading cause of death, disability, and socio-economic loss. Remember, most of the victims of traumatic brain injury are in the productive young age group. Initial management of injury is critical. Pre-hospital, in the emergency room, in the operating room, in the ICU. Of course, rehabilitation also is important, but initial part management becomes critical. Our focus as anesthesiologists, intensivists, emergency care physicians is to restore intracranial and systemic homeostasis, which gets significantly deranged after severe traumatic brain injury. As I already mentioned, adhere to the Brain Trauma Foundation guidelines because it has shown to improve outcomes. Even if you did not follow whatever I have told till now, I request you to follow this because this is very important. You need to protect your head to protect you from traumatic brain injury. Thank you for your patience.
Thank you, Dr. SriGanesh, for that wonderful talk on anesthetic management of traumatic brain injury. More so emphasizing again that avoid secondary brain injuries. That's what we can maximally do during the intraoperative period and the perioperative period. and also illustrating the guidelines, what are available, the best available guidelines based on the evidence, and how to use them judiciously, whichever is available, because we have a lot of centers where resources are limited, but we can still maximize the outcomes by using some of the common sense and some of the key things which you have emphasized. I'm sure that the delegates who are attending today are going to be benefited by it. Let's move on to one more important topic of management of subarachnoid hemorrhage. That's also one of the life-threatening emergencies, what we routinely encounter during our neuroanesthesia practice. To enlighten upon that, the management of subarachnoid hemorrhage, we have RakulPrasath from Trichy. RakulPrasath, over to you.
Yes, sir. Good evening, everyone. Thank you, sir. I thank ISA for giving an opportunity for presenting in this webinar. My topic for presentation today will be management of subarachnoid hemorrhage. And subarachnoid hemorrhage is the bleeding in the subarachnoid space, which has an incidence of around 10 to 28 cases of SAH per 1 lakh persons per year. And the major reason for subarachnoid hemorrhage is the rupture of cerebral aneurysms, which can be either traumatic or non-traumatic, followed by cerebral AVMs, and non-identifiable sources are also available. And SAH due to the rupture of intracranial aneurysms forms a significant cause of death and morbidity. So why is it important? Once there is a rupture of aneurysm, there is an escape of arterial blood into the subarachnoid space, and there is which leads on to the increase in ICP towards the systemic diastolic pressure, which further causes reduction in the CPP with the decrease in the cerebral blood flow, causing the global cerebral ischemia, with leading on to the change in level of consciousness. And when there is sustained increase in ICP, there happens a no flow state due to the very high ICP, and there is a halt in SAH progression happening, and gradual reduction in ICP can happen, and increase in cerebral blood flow can happen for a brief period of time, resulting in improvement of consciousness for a very brief period of time. And if there is a persistent SAH, there might be a formation of thrombi in cisterns, which can also cause obstruction to the CSF outflow, persistently leading to the rise in ICP and reduced cerebral blood flow, which can cause irreversible neuronal ischemia, leading on to the death and persistent vegetative state. So these patients who are with subarachnoid hemorrhage, they usually present with headache, which is the sudden onset severe headache, which is characterized as severe thunderclap headache, mentioned as worst headache of the lifetime, with a brief loss of consciousness followed by various degrees of decreased mentation, and signs of meningeal irritation can be there, and motor and sensory deficits and other neurological deficits according to the artery involved. So based on the location of the vessel, the clinical features can manifest, such as for anterior communicating artery, there might be presentation with bilateral temporal hemianopsia, and with the anterior cerebral artery, there might be bilateral lower extremity weakness. With middle cerebral artery aneurysm rupture, there might be hemiplegia happening, and posterior communicating artery, there might be third nerve palsy, and with intracavernous ICA, there might be facial or orbital pain, epistaxis, progressive vision loss can happen, and with posterior circulation aneurysm rupture, brainstem dysfunction can happen. So whenever the patients present with acute onset severe headache, if the patient is having one of the following, one or more of the following features, that is symptoms of neck pain or stiffness, age of more than 40 years, witnessed loss of consciousness, onset during exertion, thunderclap headache, or limited neck flexion on examination, which is known as the Ottawa's SAH rule. And if they present within less than 6 hours and with the new neurological deficit, then they might proceed on to non-contrast HCT to find out any SAH in the CT. And if it is there, then to find out the source of SAH, CT angiography or DSA can be performed. And if the patient is coming after 6 hours with new neurological deficit, then also non-contrast CT, it is advised to find out the SAH and to rule out and to find out the source of aneurysm. And if there is, if the patient CT is angionegative, then they might proceed on to lumbar puncture, which might show xanthochromia, which then, if it is present, then they can also proceed to the CT angiography and DSA for the further evaluation and workup. So based on the clinical features, various grading systems have been developed, but most significant of it is the modified Hunt and Hess grading system, which they have classified the aneurysmal SAH from grade 0 to grade 5. And based on the increasing grades, there might be increased risk of mortality and morbidity happening with these patients. Grade 0 usually is represented as unruptured aneurysm, with the grade 5 mentioning up to deep coma, deep cerebral rigidity, and moribund patients. And there is another grading system known as World Federation of Neurological Surgeons grading, which also grades the aneurysm from 1 to 5 based on the GCS and motor deficit of the patients. The higher the grading and poorer is the prognosis of these patients. So coming to the diagnosis of these patients, there is a non-contrast CT brain is the procedure of choice to diagnose SAH, and blood is detected in about 95% of the patients on the day of SAH, and 90% after the 48 hours, and 80% after 5 days, and 50% after 1 week of presentation. So based on the CT grading system have also been developed to estimate the risk of, to explain the prognosis and to assess the risk of SAH and to assess the risk of prediction of vasospasm, which is happening in the later stages. So they have graded from 0 to 4, where 0 is there is no SAH and IVH. In grade 1, there is minimal or thin SAH with no IVH in both lateral ventricles, and grade 2 with thin SAH with IVH in both lateral ventricles, and grade 3 is thick SAH with no IVH in lateral ventricles, and grade 4 is thick SAH with IVH in both lateral ventricles. And other modes of diagnosis are lumbar puncture, and which can show the xanthochromia after centrifugation, usually detected after 4 hours after SAH and becomes negative at 3 weeks. Angiography is used to find out the source of bleeding, and we should always make sure that we visualize all intracranial vessels to rule out the potential occurrence of multiple aneurysms. So in patients who have been confirmed with the diagnosis of aneurysms, the preoperative management of the aneurysm, blood pressure management of aneurysms has a major role, because we should avoid BP fluctuations, that is minimize the BP variability in these patients, as hypertension can lead on to rupture of aneurysm, and at the same time hypotension can increase the risk of ischemia for these patients. So the target BP is individualized according to BP at presentation and presence of brain swelling and hydrocephalus and history of hypertension and renal impairment. BP can be controlled with frequent monitoring and short-acting medications. And in patients who are already on anticoagulation, the immediate anticoagulation reversal should be done with to prevent the rebleeding in these patients. But routine use of antifibrinolytic therapy is not useful to improve any functional outcome. So in patients who are present with associated hydrocephalus with aneurysmal SAH, in case you are presenting acutely, urgent CSF diversion with either EVD or lumbar drain has to be done, and presenting with chronic hydrocephalus, permanent CSF diversion procedures should be advised. And the management of seizures, onset of seizures, if the patient is presenting with onset of seizures at the time of hemorrhage, then they should be started on anti-seizure medications for less than 7 days. But it has not been proven to improve outcome if it is started, if the patient is presenting after 7 days. And the seizure medication can also be considered for giving in patients with high risk features such as ruptured MC aneurysm, high grade SAH, ICH, hydrocephalus, and cortical infarction patients. And in this, phenytoin is associated with excess morbidity and mortality. So usually levetiracetam is usually used in our settings. So coming on to the definitive management of intracranial aneurysms, it can be either surgical clipping or endovascular coiling treatment can be done. For surgical clipping, wide neck aneurysms, inadequate endovascular access, intraluminal thrombus, arterial branch occlusion, complete occlusion unlikely, and MC aneurysms and age less than 50 years patients are most likely to benefit from clipping. At the same time, patient with having aneurysm of ratio neck-sac ratio 1:3 and difficult access, no efferent branches, high-grade SAH, extended cranial base, vasospasm, and posterior circulation are more seen to benefit from coiling. And based on the type of aneurysms, either anterior circulation aneurysms, the coiling has been preferred to clipping to improve 1-year functional outcome. But compared to long-term outcomes, both are found to have equivalent effects. And posterior circulation aneurysm, coiling is preferred to clipping to improve outcome. And patients with wide neck fusiform aneurysm, flow diverters can decrease the mortality and rebleeding risk. And saccular aneurysm, flow diverters can increase the complication risk. And regarding the timing of treatment of ruptured cerebral aneurysms, treatment within 24 hours from onset of aneurysmal SAH is preferable, and the treatment goal should be complete obliteration is preferred to reduce the risk of rebleeding. So based on whether to decide to go for coiling and clipping, international subarachnoid aneurysm trial of neurosurgical clipping versus endovascular coiling and ruptured aneurysms was done. And these results suggested that endovascular coiling was associated with better outcome at 1 year than clipping, but at the same time, rebleeding risk was more with coiling of 2.9% versus 0.9% for surgical clipping. So coming on to the anesthetic management, the goals of anesthesia for treatment of aneurysm is to prevent the aneurysm rupture which can happen during the induction time or intraoperatively, and to decrease the increase in transmural pressure gradient, and to balance the benefit of improved perfusion against the risk of rebleeding, to maintain cerebral perfusion pressure and cerebral protection against ischemia, and to provide a relaxed brain for the ease of surgical exposure with minimal retraction, and rapid and reversible titration of blood pressure, and rapid and smooth emergence with prompt neurological assessment. And other goals of anesthesia, which include the optimization of ventilation to achieve low mean airway pressure to avoid increasing ICP, normocapnia to be maintained at around 32 to 35 mmHg, and main theme is to avoid hypocapnia to prevent cerebral vasoconstriction and resultant ischemia, and to avoid hypercapnia to prevent vasodilation and cerebral vasodilation and resultant increase in ICP. And we have to prevent and treat cerebral edema, and adequate preparation to manage potential intraoperative complications such as aneurysmal rupture, and adequate analgesia to obtain painful stimuli, and provision for rapid emergence to facilitate easy postoperative neurological assessment. So intraoperative monitoring, routine monitoring, which is ECG, pulse oximetry, capnography, NIBP, temperature, urine output, ABG, and blood glucose. In addition to this, special monitoring such as invasive blood pressure monitoring, EEG, SSEP, MEP, BAEP, cerebral oximetry, TCD, NMT, and CVP can also be used for these patients. And intraop management for the induction of anesthesia for good grade SAH patients who are found to have near normal ICP, they are less prone to develop ischemia. So they can tolerate a fall in BP up to 30 to 35%. But still they cannot tolerate much fall in cerebral blood flow. So we should not hyperventilate these patients. In the view with poor grade SAH patients where they are found to have raised ICP, and they will be more prone at risk of ischemia, so they cannot tolerate much fall in BP. And for these patients, hypoventilation can improve cerebral perfusion pressure for time being. And coming to the induction of anesthesia for these patients, IV induction is usually preferred with titrated doses of either thiopentone, propofol, or etomidate according to the individual based practices. And during the main main aim should be to prevent the hypertensive responses to the laryngoscopy and intubation, and with the adequate maintenance of depth of anesthesia, and with the use of lidocaine, beta blockers, and narcotics or opioids. And muscle relaxants, usually vecuronium or atracurium can be preferred, and rocuronium is used for RSI in these patients. And succinylcholine, usually it increases ICP and causes ventricular fibrillation in patients after SAH, so it is usually avoided. Once after the induction of anesthesia, then scalpela can be given to obviate the responses during the craniotomy and during dissection of this. So coming to the maintenance of anesthesia, the maintenance of anesthesia is aimed at giving the relaxed brain adequate cerebral perfusion, avoidance of rapid increase in the transmural pressure and absolute immobility, and prompt awakening of these patients. So coming to the fluid management, the excessive fluid intake of these patients can lead on to higher fluid overload, hyponatremia, which can add on to the SADH, which might be mostly associated with aneurysm in these patients, and CHF, congestive heart failure, and cerebral edema. At the same time, the restrictive fluid management can also lead on to vasospasm, compromised cerebral circulation in these patients. So maintaining normovolemia or euvolemia is suggested in these patients to maintain fluid for these patients, and usually hypoosmotic agents should be avoided, and glucose containing solution should be avoided for these patients. And blood and blood products are usually transfused to maintain the target hematocrit of around 30 to 35. 30 to 35. So in patients who are having brain bulge during intraoperative period, the osmotherapy can be given, or lumbar CSF drain can be done, and hyperventilation can also be done for these patients. The other modalities which can be useful are head up and reducing the volatile anesthetics, omitting nitrous oxide, and giving the bolus or infusion of IV anesthetics, and furosemide can be given. At the same time, we should be ruling out the inadequate depth of anesthesia, hypoxia, hypertension, hypothermia, and venous obstruction at the neck, and intracerebral hematoma. So there will be placement of temporary clipping period, which might happen during the dissection and securing the aneurysm. So during which period the temporary occlusion or the induced hypotension can be performed. During the temporary occlusion, there will be a temporary cessation of blood flow, which is caused by temporary placement of temporary clips, which can lead on to the regional ischemia, and it is usually done for short duration of period of around 10 to 20 minutes, and it is usually that during the period of time, it is usually dependent on the collateral vessel development, and it usually offers possible complete control. At the same time, controlled hypotension can also be practiced by the systemic hypotension, but it usually causes global ischemia, and it can be preferred for longer durations, but there might be lack of complete control in this maneuver. So we should be knowing and monitoring the upper limit of occlusion duration, which usually it is mentioned here as 10 to 20 minutes, but still neuro monitoring can be applied to see to monitor the upper limit of occlusion using EEG, which is not effective beyond the burst suppression period, and SSEP can be used for anterior and posterior circulations, and BAEP for vertebrobasilar aneurysms. And we should always also take in consideration of the risk factors of the patients are prone for ischemia and infarction, in whom patients are around 60 years and Huntington's grading of about more than 3 are more prone to develop ischemia and infarction. And coming to the neurophysiological monitoring, RA EEG as well as SSEP for anterior circulation and BAEP for vertebrobasilar circulations aneurysms can be used to monitor cerebral function. So detection of any of the cerebral ischemia by these monitorings may lead on to adjustment in the surgical techniques, either removal or replacement of the vascular clip or hemodynamic management such as increasing the blood pressure to augment the collateral perfusion. So for ACOM aneurysms and AC aneurysms, bilateral tibial nerve SSEP can be done, and for MCA, median nerve SSEP can be applied to monitor the cerebral ischemia happening during the clipping period. And ICP monitoring can also be done in poor grade patients or with those with hydrocephalus. EVD, if it is placed, can reliably used for pressure measurements, particularly helpful in BP management during the induction of anesthesia and in postoperative management of patients who remain unconscious after the surgery. Though there is no dedicated guidelines for ICP management as such in TBI, whenever patients who are more prone to have increase in ICP, mannitol can lead on to serious hypertension, hypovolemia. That is against recommendation for aneurysmal SAH guidelines. So hypertonic saline can be considered superior to mannitol, since most of the aneurysmal patients are found to have hyponatremic at the same time hypovolemic. And continuous drainage has also shown to be associated with worse outcomes in aneurysmal SAH patients. So during the period of clipping and during the intraoperative period, cerebral protection has to be aimed to avoid the cerebral ischemia happening during the intraoperative period, which can be done with either non-pharmacological or pharmacological ways. For non-pharmacological, it is usually by prevention of hypoxia, hypercarbia, hyperglycemia, metabolic acidosis, electrolyte disturbances, and prevention of hypotension. And normalization of ICP and hypothermia can also be practiced. For pharmacological drugs, which can methods which include boluses, administration of boluses of propofol, barbiturates, citomediates, opioids, lidocaine, calcium channel blockers, and anticonvulsants can be considered. And newer modalities of cerebral protection has been also explained: ischemic preconditioning, erythropoietin, magnesium, mannitol, vitamin E, steroids, which is known as Sendai cocktail, and deferoxamine can also be considered. And sodium channel blockers such as riluzole, trilacid, or non-glucocorticoid 21 amino acids, which inhibits lipid peroxidation, have also been described. So once after the clipping has been done, the intraoperative angiography with the ICG indocyanine green assures the complete obliteration of aneurysmal neck and helps in recognizing the clip occlusion of the parental arterial trunk and the perforating arterial branches. So repositioning of the clip prior to emergence may decrease the incidence of ischemic complications and reduce the need of reoperation in these patients. The most dreaded complication for these patients is the intraoperative aneurysmal rupture, which has a combined incidence of 19%, and it mostly occurs during the dissection around the aneurysm and during the clip placement, and it is associated with better prognosis if it happens after the opening of dura. So it can be due to the sudden increase in the transmural pressure gradient across the wall of aneurysm, and it is usually diagnosed by the sudden increase in BP with or without bradycardia. So treatment is to restore intravascular volume with either isotonic crystalloids, colloid, and blood and blood products, and maintain cerebral perfusion, control of rise in ICP, and reduce the bleeding by lowering the systemic pressure. And it also requires rapid surgical control by placing the clips. After restoration of intravascular volume, MAP can be reduced briefly to 40 to 50 mmHg to facilitate the clip ligation. And it can be also done by temporary occlusion of parent vessel proximal to the distal to the aneurysm, and temporary bilateral carotid artery occlusion can also be considered. And there must be good communication between the anesthesiologist and surgeons through the and video monitoring of the placement of aneurysm clips can also be considered. And coming to the emergence and recovery, avoiding of coughing, straining, and hypercarbia and hypertension is essential. So antihypertensives can be used to avoid ICH and cerebral edema, and longer-acting narcotics to confer analgesia in immediate postoperative period can be considered. And maintenance of BP within 20% of normal baseline values during the emergency is mandatory. And relative hypervolemia or euvolemia is maintained, and persistence of any unresponsiveness or development of any new neurological deficit for 2 hours after the surgery usually necessitates a CT scan. So whether to decide with to extubate or not extubate a patient depends upon the aneurysmal gradings, which you have seen before. Patients with good grade aneurysm, that is grade 1 and grade 2, and uneven full surgery, we can go ahead with reversing and extubating the patient on table. And patients with either grade 3, the extubation will be determined by the preoperative ventilator status and duration and intraoperative course of the surgery. And patients with poor grade aneurysms such as 4 and 5, it is better to keep the patient intubated and provide ventilatory support on neuro-intensive care in the postoperative period. And patients with intraoperative aneurysm rupture or vertebrobasilar aneurysms, immediate extubation may not be possible, and they will be needing postoperative ICU care. And coming to this endovascular treatment of aneurysms, the anesthetic considerations are same with few exceptions, except in the such as location, it will be done in the neuroradiology suite, and blood loss is usually less, and there is no need for brain relaxation in these patients. And endovascular coiling has also been associated with its own complications such as aneurysmal perforation, thromboembolic events, and occlusion of the parent vessel from coil herniation, and other non-CNS complications such as contrast reactions, contrast nephropathy, hemorrhage at the puncture site, groin hematoma, and retroperitoneal hematoma. So these hemorrhagic complications may lead on to increased ICP with preparation presenting with headache, nausea, vomiting, hypertension, bradycardia, with changes in the level of consciousness. If the aneurysm rupture during coiling, the immediate reversal of heparin by protamine 1 mg for 100 units should be considered, and radiologists should be immediately try to secure the ruptured segment by coiling and inducing thrombosis. And maintenance of BP in the low normal range is advised, and the immediate rise in ICP mandates putting EVD in the cranium after burhole and taking the patient to OT for urgent neurosurgical intervention. For occlusive complications, both thromboembolic and vasospastic require deliberate hypertension titrated to the neurological examination with or without direct thrombolysis or angioplasty to improve the distal perfusion. And it can be a volume expansion can be considered, hyperventilation, anticonvulsants, hypothermia, and vasodilator therapy for cerebral vascular dilatation can be considered. And in the postoperative period, for the hemodynamic management in the patients with who are at the high risk of vasospasm, the BP should be maintained at around 10 to 20% increase in BP above the preoperative baseline may be of benefit. In patients with multiple or unclipped aneurysms, BP should be kept within the 20% of the normal, and to avoid a rise in the BP in those patients. And we should at least ensure normotension and target normovolemia. And postoperative monitoring includes hemodynamic monitoring and flow monitoring of the cerebral blood vessels using TCD, and clinical examinations in of new onset any new focal neurological deficit to find out any surgical cause. And we should examine pupillary examinations, and neurological status is usually assessed every 15 minutes in recovery room or intensive care unit. And metabolic factors and metabolic disturbances, electrolyte disturbances should be also assessed and treated, and immediate CT or angiogram should be performed in case if any new onset focal neurological deficit or any anisocoria if it is happening. For pain management, NSAIDs and opioids under close monitoring can be considered. So in patients who are patients who are presenting with aneurysm, they are more prone to have the risk of delayed cerebral ischemia. So these patients are usually started on oral nimodipine on the day 1 itself, and it is continued for 21 days of 60 mg of 4th hourly, and followed by regular neurological examination. So by TCD monitoring and continuous EEG. And if there is usually this prophylactic hemodynamic augmentation is usually avoided, but if there is proven vasospasm or DCI, then hemodynamic augmentation is considered, and endovascular rescue therapy can also be done with IV spasmolytic or angioplasty can be considered. So to conclude, this aneurysmal subarachnoid hemorrhage is a life-threatening emergency requiring timely diagnosis and intervention. Both clipping and coiling aim to secure the aneurysm and prevent rebleeding, but the choice depends on patient profile, aneurysm characteristics, and the institutional expertise. Endovascular coiling offers lower morbidity and faster recovery in selected patients, while surgical clipping provides more definitive treatment with lower rebleeding rates. Anesthetic management is critical to optimize outcomes from induction to the emergence, and careful control of cerebral perfusion pressure, ICP, and hemodynamic stability is essential. Individualized preoperative care, interdisciplinary coordination, and awareness of potential complications are key to improve survival and neurological outcomes in these high-risk patients. Thank you.
Thank you very much, RakulPrasath, for extensively covering the management of subarachnoid hemorrhage, including the perioperative management, including the cerebral protection strategies and intraoperative aneurysm rupture, which is a dreaded complication. So we'll have some discussion. There are some questions in the chat box, and I'm going to moderate them. The first question is that to the Rajasekar, the question is that by pre-op assessment, can we predict post-op extubation timing? Like how is the patient presenting? How do you decide on extubation? Like if the patient is with the EDH, acute SDH, is it based on GCS alone, or how do you actually go about planning the extubation of these patients?
There's not going to be a single factor which can predict a post-op extubation, but the most important one would be the GCS, the presenting GCS, and also the neurological, the imaging finding. Patients with EDH usually respond well, like immediately after the evacuation of the hematoma. They usually present with an mild GCS, higher GCS as well. But patients with an STH with significant midline shift, we have a significant contusion, they're going to take time for recovery. So GCS and the imaging would be one factor which I would consider. The other one would be the other injuries that the patient might present with. If he is also having a multiple rib fracture and all those things, there could be a delay in weaning. Also, the hemodynamic stability at the end of the procedure. They might be stable preoperatively, but with the blood loss and all those things intraoperatively, they might not be hemodynamically stable. So based on the hemodynamics, the presenting GCS, and also the brain findings, both on preoperative imaging as well as intraoperative findings, are going to be a decisive factor in the plan for extubation.
Okay. Okay. Dr. SriGanesh, if the brain is increasingly tense in the intraoperative period, which we commonly encounter in these TBI patients, and there is a question that in spite of osmotherapy, still the brain is bulging. Okay, so what to do?
Yeah, it's a very important question, especially for the postgraduates and practitioners. That is a common finding during the surgery. But we must remember that it is the acute phase. This is acute severe traumatic brain injury. That is a very small subset of population. About 10% of all patients with traumatic brain injury we are seeing. So it is quite natural to find a full brain. Now, how do we go about managing it? Now, suppose the patient has an extradural hematoma. You cannot give osmotherapy as well, which is not of no use in extradural hematoma. So how do we go about? So here you have to facilitate early and quick evacuation of the extradural hematoma. Removal of the hematoma itself will release the pressure in the brain and restore functions as quickly as possible. Suppose it is an subdural hematoma. Here the lesion could be very small, but the underlying edema could be more. So here again, as soon as you open the dura, you see the hematoma, evacuate it. But still, the patient may have a full brain. Osmotherapy is definitely indicated, hyperventilation is definitely indicated. All other measures like head and elevation, positioning, neutral position may be difficult during surgery, but all other measures, hyperventilation, could be instituted till you take care of the hematoma. These are simple intervention, easily doable, but despite all this, brain can still be full, and then you can advise the surgeon, or surgeon himself decides he will not place the bone back. Now that is because the brain can expand. The injury is still ongoing despite removal of the hematoma. So you keep the bone in the abdomen or in the deep freezer, what is known as a decompressive craniotomy. And later on, subsequently, once the ICP settles down, brain swelling comes down, you can place the bone back. I think, sir, I have answered your question, or if you have some more query, I can still take.
No. See, the problem is most of the time, for the benefit of youngsters only asked. See, if there is a tumor and suddenly if the tumor bleeds, while they want to evacuate or remove a portion of the tumor, they want the soft brain. But at that time, most of the time, since my postgraduate days, it is increasing, is bulging, and we don't know what to do. Then at that time, I asked that our NIMHANS man, Dr. What is his name? He was my examiner. Umameshwara. He was my examiner and he was my quiz master also. I got already a second prize quiz. So December I got prize from him, and March he was examiner. Then I asked him during the daytime, sir, how we are managing. At that time, they were using large dose of thiopentone sodium. But even now, I don't know what to do really. It is bulging. Then we say, sir, we will wait See, we could not do anything because you are routinely doing it, I am asking. Because we are once in a month we will do, you will do 30 per day. So that is a difference. I was asking you.
Sir, for the tumor set is different because it's an elective case. You
Yeah,
have time
whatever
to.
it is, I'm asking, see, if it is going, because you would have seen,
Correct.
that is the reason I'm not saying tumor. Tumor bleeding, it is also because of a trauma, something can happen. At the time, it's really difficult, so they have to manage.
Yeah, I think there's a role for both anesthesiologist and also surgeon. We
Ah.
forget sometimes surgeon himself can take care. Suppose it's a small frontal lesion, functionally not so important. Just a lobectomy is good enough to preserve functions of the
Yes.
other vital structures.
See,
And
I
placement of
talked
IUD.
about this in Vidiyanagaram, how to reduce ICP. At that time, I said brain is having some contents. One is a brain, another is blood, another is CSF. So you can control CSF by your PaCO2. You can control the same way your blood volume. At the same way, you can remove brain also to reduce in ICP. See, it is a component of brain. You have to remove brain also.
Very well.
There are so many questions now.
Yes, sir. Despite that also, still that brain can be bulging only, sir.
Yes,
Even
yes.
after
I
a
had a
certain
case
point
of
of time, nothing much. Yes.
bifrontal lobectomy. A patient, what is the use of keeping him? We kept him on ventilator. The son wants to have them. Trichy only they have done. Bifrontal lobectomy, I was ventilating in Tanjavur unnecessarily. I'm explaining. See, once there is a bifrontal lobectomy done for this hemorrhage, traumatic hemorrhage, they could not control, they have done. What is the use? But they want me to ventilate. We have ventilated with the tracheostomy also. That happens.
Yes, sir. Yes, sir.
Other questions are also there.
Yeah, yes, sir. This regarding there is one question on dexmedetomidine. Is it cerebral protective? Can be used in ICU as an infusion? What is the evidence, sir? That is for SriGanesh, sir, only.
Yeah. So definitely, sir, dexmedetomidine is definitely not harming the brain. Can be a cerebral protective because it reduces inflammation. It has beneficial effect on sympathetic activation. Only concern here is most of the patients with acute severe traumatic brain injury will have a Cushing's reflex or response, where patients can have a bradycardia and hypertension. So you will have to balance it out with the considering that it can dexmedetomidine can further decrease the heart rate. What I generally do is I don't give bolus dose because that is when patient can manifest with bradycardia with hypertension and confuse the picture. Now, bradycardia is an early sign of worsening neurological status or impending herniation. Now, you add dexmedetomidine, it can complicate our decision making, clouding the facts. But with this in background, you can still use dexmedetomidine. It's a wonderful analgesic, wonderful sedative agent, preserves respiration. Even if you are you not have ICU bed, you can start dexmedetomidine, control an agitated patient, provide some sedation, provide good analgesia, and use it in the ward in high dependency unit as well. There is plenty of evidence regarding the use of dexmedetomidine as analgesic sedation. Now that is the term that is used in neuro ICUs and I think in other ICUs as well. So it's a very good. It provides both analgesia and sedation, and probably the only drug which does it that effectively. So both evidence and regarding cerebral protection, yes, sir, I think it can be used.
It's Dr. Rakul, somebody is asking that if there is a chronic hyponatremia, for example, sodium level less than 130, can it be taken as a surgery, or do you have to wait, or in case of emergency, how long we can wait or we can take it up?
Sir, in case of an emergency, it is better to take the patient for surgery because there might be risk of re-rupture happening with these patients and there might be stress in the perioperative period which can happen. So it is always better to consider taking the patients for surgery, and simultaneously correction of hyponatremia can also be started for these patients. Sir, and patients with aneurysmal esophagus, they are more prone to have this hyponatremia because of this SAADH and also. So simultaneous correction and taking the patient for surgery is usually advised for this patient.
Also, can you throw some light on TCD for the benefit of the postgraduate students?
Yes, sir.
Doppler use and.
Yes, sir. For the transcranial Doppler, it usually helps in monitoring the blood flow of the cerebral blood flow. Velocities can be seen, sir. So these aneurysmal patients usually they have high risk of having vasospasm, and which might lead on to development of DCI. So to prevent the DCI and to diagnose at an early stage and start the treatment, this the frequent monitoring of TCDs and the flow velocities can be useful, and the ratios can be also seen, like pulsatility index and mean cerebral artery, cerebral blood flow velocities of middle cerebral arteries, and AC and posterior circulation can also be done frequently to find out whether if there is any increase in cerebral blood flow velocity, such as if it is usually graded as mild, moderate, and severe from more than 120, 150, and 200, and based on that, the severity of vasospasm can be diagnosed, and the patient can be taken early for the treatment of vasospasm, and the angiographic spasmolytic can be administered for these patients, and frequent monitoring can be done.
Dr. Raj, there is a question asking that any precautions for patients on anticoagulants in traumatic brain injury at the pre-op assessment?
For one issue would be like we won't get the time to get a proper history. Basically, one issue is that. Second thing, if the patient is on anticoagulant, we don't have the time to get the lab values. So these are two things. But in particular set of patients who are on anticoagulants with a trivial injury, they might end up with TBA. These are the patients whom we have a proper history, what medications they were on. So such patients, we can simultaneously treat the anticoagulant reversal as well as take them for surgery. So we do not wait for the reversal for the to get acted, then you do not take them for surgery. We simultaneously do them. So most common drug would be warfarin. So we administer vitamin K and we do take up with FFP and platelet covers. So we do not wait for the reversal. And other new issues with the newer anticoagulants, the oral anticoagulants, though antidotes are available, which is not so frequently available. So once again, we'll have to rely on the products. So instead of transfusing them preoperatively, do not waste time on the preoperative phase, take them up surgery and simultaneously correct it in the intraoperative phase.
Dr. SriGanesh, are you using this 3-factor, 4-factor PCCs? Is it considering the cost? I am surprised whether the hospital will have it.
No, but we do have tech available. So we can identify what exactly is the abnormality, why there is a bleeding, identify which substitute can be appropriately used. But I agree with you, PCs are not frequently available. So we still rely on FFPs, flesh frozen plasmas to be administered, and reverse if any reversible antidote if they are available. But most often this is how we manage.
Okay. So what about muscle relaxants? Are you using routinely in your ICU or just a sedation?
Yeah, if you are able to provide good analgesic sedation with opioids, with dexmedetomidine, with propofol, or with depending on the timing of traumatic brain injury, depending on the ICP, depending on whether patient is operated or not operated, choice of analgesic sedation can vary. So role of muscle relaxant, at least in our IC, is very, very less. We don't use it. But I know many centers use muscle relaxant, and recently we have observed that the CPP opt, now we are moving to what is known as CPP opt based on cerebral autoregulation and pressure reactivity index. We found that CPP opt can be better achieved without the need for significant vasopressors if the patient receives muscle relaxant. Now that is something which we learned recently, because we have been not using muscle relaxant for several decades now. And so I don't know whether this is going to come up again, but again, it is an individualized approach. Suppose the patient has ARDS and a severe traumatic brain injury. We definitely use muscle relaxant to achieve better oxygenation, which can translate to better outcomes in a patient with traumatic injury. But for routine TBI, isolated TBI with no other secondary reasons for administering muscle relaxant, we generally avoid.
So how about this hypertonic saline? Are you using as a continuous infusion in the ICU?
Yeah, we use hypertonic saline both as a bolus and as a continuous infusion. We generally use about 4 ml per kg or 5 ml per kg of 3% saline as a bolus. And if you are monitoring frequently, then bolus is, can be method of administration. But if you don't monitor that frequently for electrolytes, then a continuous infusion could be better. So depends, 3% saline of 10 ml, 15 ml, depending on the scan, depending on the patient's condition we use. Most often that is the agent of choice, because our patients are unstable on vasopressor either because of the use of propofol or even their blood pressure is low after surgery, awaiting transfusion or ongoing transfusion. So in those situations, we use hypertonic saline. Yeah.
Okay.
Dr.SriGanesh,
Yes, sir.
I want to ask, previously morphine was contraindicated in head injury because it interferes with the pupillary reflexes. That was a teaching. So when I was in ICU, I used to do it with the morphine because I used to ask the neurophysician, how many of you are diagnosing the condition with the pupillary sign? You are asking for serial CT. So every time CT, and now we have transport ventilators, we are transferring the patient. So even in my ICU, with the hand ventilation, we will transfer for CT. So now I want to know, instead of using this dexmedetomidine, it's R-etomidate, why can't you use a stiff dose of morphine to avoid relaxant? Because I am also not for relaxants. So whether any contraindication for this narcotic agents in brain injury as of now, when they are not seeing the pupillary reflex?
Absolutely no contraindication for opioids. Opioids are excellent for managing analgesia and also providing sedation. We use morphine liberally in our ICUs. Of course, sometimes we use fentanyl because infusion pumps are available and better titration. Quickly you can taper off the agent. Morphine has a little longer effects, residual effects. We also have pupillometry. Now, what the nurses do at bedside may not be very objective. I may say it is reacting, somebody else may say it is not reacting. So there is a confusion. So we use an objective tool called pupillometry, which is easily available for 2.5 lakhs, which should be used regularly. It provides not only pupillary light reflex, but it also tells accurately the pupil size. So this confusion that it will affect pupillary is no longer valid. Tools are increasing, better availability of newer gadgets. Cost is not a factor nowadays. Most of the ICUs can use. So, but your question, opioids, can it be used? Absolutely, you can avoid muscle relaxant with use of opioids.
Thank
So
you.
I used to tell the neurosurgeon, rather than shifting repeatedly, you write in the chart itself BD, TDS, CT scan. So now they have shifted the CT scan itself to the ICU. Now mobile CTs are available.
That is better. Bedside CT.
So better to
Bedside
refer the mobile
CT.
CT, bedside CT, which is easier for us.
So
than-
instead of PET scan, we can have bed scan.
Yes. Yes, sir. Thank you, sir. Over to
Thank
you.
you. Sir, sir, thank you very much. We are happy today because you have given us a lot of time for interaction by concluding it early. That is a good thing. So in future also, I request all the faculty who are listening to this webinar to follow that, because there is sufficient time for interaction. So now I request Dr. Hema, our treasurer, to propose formal vote of thanks.
Thank you, sir. Good evening, everyone. I thank you all for your presence in our 29th episode on Puthukkottai Bhudhan on the topic on traumatic brain injury. Our sincere gratitude to our academic chairman, Dr. A.L.M. sir. Sir, congratulations, sir. I thank Dr. Rajasekar, senior resident, Neuro Anesthesia, JIPMER, Puducherry. I thank Dr.SriGanesh, professor, NIMHANS, Bengaluru, Karnataka. I thank Dr.RakulPrasath, consultant, Neuro 1 Hospital, Trichy. Thank you, sir. I thank our moderator, Dr. Prasanna Bidkar, professor and unit head, JIPMER, Puducherry. Thank you for guiding us today, sir. Thank you, sir. Thank you, Clarinet, for your continuous support. I thank all the postgraduates, colleagues, and participants for your continuously encouraging us. Thank you. Have a good evening. Thank you, sir.
Clarinet, for your concluding remarks.